And I'll ask our Dr. Wilder to start sharing while I introduce him. So I'm very actually honored and excited to hear Dr. Julius Wilder, who is joining us from Duke University. Dr. Wilder obtained actually the first MD and PhD in medical sociology in the history of Duke University. Following his completion of internal medicine at Duke, he has finished his fellowship in advanced hepatology and GI. He's currently an assistant professor of medicine, and he is also the diversity chair for Duke Division of Gastroenterology. His interest of healthcare disparities, especially at this time, which is even more topic for COVID-19, is very active in research and education. And with that, I will pass on to Dr. Julius Wilder. Thank you.
Thank you. Thank you so much. And thank you all for having me. It is certainly an honor to be here. I'm excited to discuss this topic with you. Certainly the timing is important. What I'd like to do is to first take a moment and just kind of reflect on what we've seen play out with respect to COVID-19. We've seen tremendous disparities there. And it's important that we just reflect and understand the social determinants that have driven the disparities that we see in COVID-19. That's important because it helps us begin to see the connection in terms of our patients with chronic liver disease that are at greatest risk for COVID-19. And then we begin to see the areas where there are clear connections. There is tremendous intersection when trying to understand what drives disparities in liver disease. And then there's places where they kind of come together, unfortunately, to really create the perfect storm for challenging issues in our patient population. There are no relevant disclosures I have for this talk this evening. So again, I want to begin with talking about the social determinants of disparities in COVID-19. I think the first thing that is important to reflect on is how quickly we got to where we are. I don't know what happened to the year 2020. Lord knows we know what happened in the year 2020, but it really flew by. And this pandemic hit us so quickly. We all remember what happened. In fact, before the session began, we were having a conversation about what we're doing around this time last year. We first heard about this strange new infection in Wuhan, and then a month later it was outside of Wuhan. Then a month later after that, it was the first death outside of China, and then right after that, and now the WHO declares it a pandemic, and it just kind of grew and grew and grew. And we know what happened from there on to where we are right now. But this happened so quickly. And what that means is that we weren't prepared. And also, as we talk about this, it's important to keep in mind that those who were at the greatest risk at the beginning were certainly going to bear a disproportionate burden as things progressed. Okay? And we had more adverse outcomes. And so if we take a step back, this is from January 11th of this year, and we just sort of look at the United States, looking at the deaths per 1 million folks by state, you can see where we've come. We've had a tremendous number of tests. The cases are just enormous number of cases. Unfortunately, that number has certainly grown. Over 130,000 recently hospitalized. And then, of course, when thinking about deaths, you can see we're approaching right at this point almost 400,000 deaths. In fact, we had more deaths last week from COVID last week than we did from the flu the previous year. And so this has been tremendous and horrific, honestly, in terms of its impact. And if we just look over what's happened since April to now, you can see that it's not slowing down. This thing has grown and grown and grown. And with the holidays and with the travel, we've just seen it get worse and worse and worse, such that, we have been hitting records almost weekly with respect to the number of cases, with respect to the number hospitalized, as well as respect to the number of deaths, okay? The interesting thing about this story with COVID is that early on, you may recall the first, we're talking about California right now, right? And certainly, you all are on our thoughts. You are all in our thoughts and prayers. We know the burden that you guys have right now with resources of COVID. But the first hotspot you may recall was actually in New York. And it was in New York that we began to see this pattern. And so, there was some data looking at just the zip codes or where you were, the borough you were in. And looking at the borough, you could see based on who you were and where you lived, how that correlated directly with the likelihood of you having COVID-19 in the first place and getting sicker. All right. And so as we took a step back, to sort of see the lay of the land more broadly, all right, and this is going back into last year from sort of March to November range, this data here, what we're seeing is that if you look at minority populations, particularly African Americans and Latino populations, we see that there is a tremendous disproportionate burden with respect to deaths as well as with respect to cases. And that's in most states. I'm in North Carolina. We certainly saw this be the case in North Carolina, particularly when it came to deaths in the African American population. If we look at the Hispanic Latino population, you'll see a similar pattern. Now, as we get into some different populations, one of the issues, and this is an issue to think about with COVID-19, especially in our liver patients, because of the importance of it and the way it interacts and intersects with liver disease, is a lot of times missing data is a problem. And so what you're going to see here as we get into the Hispanic Latino population, again, a tremendous disproportionate burden with respect to cases, as well as with respect to deaths. But you're starting to see that there's a lot of missing data, particularly when it comes to deaths. And so what I would argue is that when we begin to understand the burden of COVID-19 on our patients and our patient population, we're probably underestimating the true burden, generally speaking, and we are certainly underestimating the burden with respect to deaths because of how difficult it's been for us to accurately capture that data, particularly early on. That having been said, you can see the pattern here in that population and looking at the Native American population as well. And again, you can see here, even more so, a lot of insufficient data. And we can go on about other unique populations in the United States where we've seen this pattern of a greater burden with respect to cases and deaths, okay? And so why is that? And so I'm a medical sociologist. We believe very much in the idea of structure and the fundamental cause of disease and environment. And as you may have ascertained from that initial slide about New York, neighborhood is important. Who you are, where you live, what your life course has been has a tremendous impact on your health. And it begins from the day you're born. Congratulations, Dr. Fix, and a new baby. It begins in the day you're born, and it goes to where you are right now. And so if we look at Black and Latino neighborhoods in this country, they're extremely segregated neighborhoods, and that has a meaning. They have a lived experience in those neighborhoods. And so when you are living in an area where there's a higher density with respect to your ability to social distance, when you're living in an area where there are less resources, then that's going to have a direct impact on your health. And what we found is that when looking at Black and Latino neighborhoods in the United States, they tend to be living in places where there is a higher density of people. They live in higher density households, and all of that increases the likelihood of them being exposed. Right. So when you think about your liver patients, the patients who are at greatest risk, or whoever patients you're seeing, understanding what is their risk of COVID-19 is important. And one of the reasons that we're seeing higher COVID-19 in minority populations is simply because of what it means to be who they are and where they live. In this picture on the right, this is where I grew up. Bethesda, there's where NIH is. I grew up in Montgomery County, which is right up top. And this is not about Democrats and Republicans, although I'm sure that's on everyone's mind right now. But what you're seeing blue is where predominantly Black folks live in the metropolitan area there, and the red where primarily white folks live. And you can see some areas of yellow where there are larger Hispanic and Native American populations. This is really speaking to is this idea of residential segregation. It is a serious health issue for all of our patients, particularly liver patients, and we'll talk about that here in a few minutes. And as we begin to wonder about why we're seeing this disproportionate burden, it helps us understand why these disparities exist in COVID-19. It is a structural issue that's been here that COVID-19 took advantage of and has really driven the disparities that we're seeing. Now here, this is some data from Drexel where they actually measured neighborhood structural susceptibility and linked that, right, to crime, access to fresh fruits and vegetables, healthcare resources, these measures of neighborhood structural susceptibility, and we're able to link that directly to greater rates or positivity rates of COVID-19. All right, so again, where you live matters and can drive your risk. But when we try to understand what are those sort of structural or social determinants driving these disparities, okay, it's not just where you live, but it's how you work. And where you work, so to speak. And so when you look at Black, Hispanic populations, particularly, what you're seeing is they're more likely to work in places where they are, unable to avoid contact. Okay, they can't be social distance in the kind of work they're doing. And even more so, they are unable to work from home. Right. And so similar to what we were talking about in terms of neighborhood and density, we're talking about a scenario now with respect to occupation that leads to an individual being more likely to be exposed, just speaking, to the pandemic. Something I think gets lost a lot of times in the pandemic, and I'm not sure if any of you all saw President-elect Biden's address a few minutes ago, actually, but he spoke about what this has done to the economy. And it's pretty scary. We're talking about the steepest recession that we've seen since the 1990s, and it hasn't even gotten to the bottom yet. They anticipate that it will get worse. And when you think about our patients with liver disease who are at greatest risk to begin with respect to SCS, right, and lower medium household income, lower wealth, then begins to make sense that they are at the most exposed, at greatest risk in the setting of a quarantine and a pandemic that has such a significant economic impact. But compounding this whole issue is the fact that when you try to understand the differential impact of the pandemic and the recession, it actually is not just it's not just that they are at greatest risk because of where they are at the beginning. It's that the economic impact was worse on people at the lowest rungs of SES. So what you're looking at here, the last major four recessions, 1990, 2001, 2008, and of course our current one with the coronavirus. And what they're showing you here is that the unique thing about this specific recession, largely again because of the need to quarantine, social distance, and how it's affected things like unemployment, wages, and so forth, is that the people who are the most economically disadvantaged to begin with were the ones, again, most impacted, unfortunately, negatively by this pandemic. And we'll talk a little bit more about how this connects in terms of mechanism to liver disease, but I think you can begin to see how it clearly plays a role. And so as we think about COVID-19, and we're going to do the same thing here in a couple minutes with liver disease in respect with COVID-19, this is sort of a conceptual model to think about the role of, in this case, race, right, which acts as a fundamental cause of disease. It acts through multiple intervening mechanisms, such as, resources. It can be economic, social, healthcare resources. It impacts risk of exposure, risk of complications. Structural racism is a key player. That there's an undercurrent that drives a lot of what we see in terms of race and health. And all that has impacted what we've seen in terms of COVID-19 and health disparities. And so if we're going to have a conversation about liver disease and COVID-19, we must understand that those disparities exist and why they exist, because the same mechanisms are at play when trying to understand how we recognize the burden of this in liver disease patients and how we and what potential solutions we may have. And so let's just talk about the direct effects, right? So COVID-19 obviously can increase liver enzymes, and my colleagues will speak more to this later on, but it can have some modern impact with respect to your liver enzymes. And we've shown that, in terms of patients that are inpatients with cirrhosis, having cirrhosis and COVID-19 is a higher mortality risk than in patients with COVID-19 infection alone. And also, by the way, that ACE2 receptor is important, right? That's how it affects the GI tract as well. And it's also how it impacts the lungs and the heart. And so when thinking about the direct effects of COVID-19 on the liver, thinking about managing these patients, it really acts through a multiple intervening mechanisms, right? We know about the cytokine storm, which is that scary thing we've all heard about. I've seen actually drug-induced liver injury from people trying to manage their own symptoms in the setting of having COVID. And then, of course, we know about the cardiac effects through the ACE2 and with clotting and cardiomyopathy, and of course, the direct effects. And so when thinking about the direct effect of COVID-19 on the liver, there's there are multiple mechanisms at play. But when we try to understand more broadly what is meant managing liver disease, it's the indirect effects that act through social terms of health, very similar to the ones that drove disparities in COVID-19 in the first place, that I want us to reflect on. And so let's just talk about access, right? I mean, we've all seen tremendous drop with respect to clinic visits. When we shut things down here at Duke in March, and we had a tremendous drop, obviously, with respect to visits because we weren't prepared. We didn't have PPE. We didn't have the infrastructure to provide care in the setting of this pandemic and the quarantine. And what you're seeing here is that in multiple types of chronic liver disease, we saw the same thing occur, where there was a tremendous drop over time compared to the previous years in terms of the amount of liver clinic visits. Along the same lines, we saw a tremendous drop as well in terms of ultrasounds and other types of imaging, CT, MRI. And so again, this is particularly relevant, right? Because the patients that we're getting these ultrasounds on MRIs every 6 months, are going to be our patients who are sicker in the first place. They have cirrhosis, there is concern for HCC. And so obviously our ability to provide care was significantly impacted. One of the things that we thought about that we were able to implement was telemedicine. Here at Duke, we had not implemented telemedicine, quite frankly, into our practice. we were able to, over about a 7 to 10 day period, implement it very quickly through Epic. It took a number of clinic visits for all of us to become good at it. And telemedicine can be a very powerful tool, right? What I want to do is, as we talk about these sort of issues that drive disparities for COVID-19 and liver outcomes, I want to talk about the solutions as well. And so telemedicine is a great potential solution. It certainly is a valuable tool when trying to think about how we can more broadly provide care to patients. And quite frankly, I think we all recognize now that telemedicine is something that's here to stay. It's not going anywhere anytime soon. But although 80% of households have internet, there remain significant challenges. There is not equity in terms of internet and broadband services. What type of internet do they have? Is it dial-up? And is it a high quality internet? What are they using? What kind of computer do they have? There's so many things that come into play. And so when thinking about how you can leverage telemedicine as a tool to reach your patients, particularly those patients, right, that we've talked about that more likely to have been affected by COVID-19, that are already disproportionately impacted by liver disease, when thinking about minority populations and people with lower SES, it's important that you think about ensuring that they receive their information ahead of time with respect to telemedicine, and that they are prepared, and that someone's had conversations or communicated with them to understand what their needs are. It's important to have IT available to provide help if there are connectivity issues. That was extremely important for us, particularly early on, really with all of our patients, but particularly with many of our patients of lower SES and many of our minority populations and older patients. And honestly, a lot of our clinic visits would not have happened if we did not ensure that they were able to use their phones as backup. Interesting enough, we actually did a study at Duke looking at our clinic visits in the setting of the pandemic and telemedicine. And what we're able to show is that minorities, people who were older, people of lower SES, were more likely to either have a missed appointment, never connect, to have a failed televideo visit, and more likely to use ultimately telephone for their clinic visits. And so, and these are people who had internet. And so it's important, again, that we understand telemedicine is important. But if we're going to continue to leverage this tool, and I think it's here to stay moving forward, we need to begin to build an infrastructure that will support all of our patients, those who have great internet and who are very nimble with it, but also, those who are not as comfortable with technology or are not as connected, right? And if we're going to think about equity, right? Because the important thing, I'm using the word equity on purpose, because equity doesn't mean we all get the same thing. Equity means that we make sure everyone gets what they need so that we all are doing well or succeeding or healthy. And so it might be that there is increased resources that need to be put into certain places or into certain communities to get the type of internet and broadband service that they need. And this is why. So over time, we've seen tremendous increase with respect to internet use and access, generally speaking, across the board, what we're seeing here. But when we delve a little more into the details, there are not a big differences with respect to sex or gender, but we do see tremendous differences in terms of internet access and education level, all right, where those who have less than high school are much less likely to have access to internet. Similarly, looking at age, we see a tremendous difference as folks get older, obviously extremely relevant for us in the patients that we tend to see with chronic liver disease. And not surprisingly, income correlates well with education as well in terms of access to internet. And then finally, the race ethnicity differences are not insignificant. I think a lot of the differences that we see in terms of race ethnicity in our clinic and our data are largely related to SES there. And similarly, you can see the same things here in terms of rural and urban. Those differences should be bigger. But I will say it's important that even when you see these similar comparisons in qualitative data, we can show that the quality of the internet and the likelihood of losing that connection, even when they quote have internet, is higher in both of these populations. So we've talked about broadly the idea of sort of social determinants and how they've driven disparities in COVID-19. And we've talked about how it's impacted resources and care, broadly speaking, in terms of access to resources, clinic, and so forth. So now let's look directly at some of the data and the mechanisms in terms of the day-to-day care for our patients with liver disease. And so, at baseline, we know that many of our patients are disproportionately impacted by liver disease, racial ethnic minorities, our low-income communities, non-US born groups, and that social terms of health is driving this. And these, again, are shared mechanisms that were driving the disparities that we saw in COVID-19 in the first place. And so here, if we're just looking at, liver disease and COVID-19, no COVID-19, just chronic liver disease, the hospitalization rates have been higher in the setting of the pandemic. In the setting of having just COVID-19 and not chronic liver disease, we're still seeing higher rates in African Americans in terms of hospitalization rates. When you combine the two, you can see how they come together, right? To increase a sort of larger burden in terms of having COVID-19 plus chronic liver disease. So we're seeing these mechanisms come together to drive this, regardless of whether you're at play in terms of COVID-19 or chronic liver disease. And then, of course, coming together merged across these great disparities when both things are present. And this is the case with respect to hospitalization as well as with respect to death rates. Again, regardless of whether you do or do not have COVID-19 or chronic liver disease, we're seeing higher death rates over time here in the last year among African Americans. But we can see the tremendous disparity that exists when you combine COVID-19 plus chronic liver disease in that burden. And this is us, and that's with us knowing that at baseline, having COVID-19 plus advanced liver disease cirrhosis, you're going to be at greater risk mortality on an inpatient service. So I want to talk about a couple specific examples that we can think about when trying to understand these disparities, and then we'll get into some of the potential ways to address these issues, because it's important to plan ahead, because I think we're going to be dealing with these issues in our liver patients for a good while moving forward. So we think about Hispanics, for instance, in fatty liver disease. There's a tremendous burden of that in that community. And we all, I mean, I remember the shock of going to the grocery store trying to buy some milk and there not being milk there. I mean, that's something I never thought would ever happen. And I'm a person who was never struggling financially, and I'm fairly healthy, and so I wasn't concerned about my health. But food insecurity before COVID-19 is a very real thing for many of our patients, and we know to be an independent risk factor for fatty liver disease. So that's even been accentuated, obviously, in the setting of COVID-19, particularly in those communities at greatest risk. I've had many of my patients talk about their fear of going, to get fresh fruits and vegetables and going to the grocery store, right, because of the issues with, again, they're concerned about getting sick. So this has led to people not eating healthy. Of course, that can drive decompensation. And so here we can see where SCS and COVID can drive directly the impact on our patients with liver disease. Again, we talked earlier about occupation and the kinds of jobs. Well, one of the questions, I remember an argument I had with one of my nurses. She was like, well, why don't they just quit if it's a job's the problem? Well, because of the job losses and what it means to lose your job right now, they can't afford to quit. They don't have the savings to do that, to get through that. And so we've had the worst global recession in history. The job loss has been significant because that, of course, is how many of us in this country have health insurance. You think about expensive medications like rifaximin. You think about the need for, procedures that we talked about earlier, imaging, those types of things. That can be tremendous, gaps in care that can have significant implications on people's health overall. Again, worsening symptoms and increased hospitalizations. And then there's, again, what the quarantine means. The social isolation, how it's affected interpersonal relationships. Individuals have been very isolated. They have not gotten the kind of support that they need. I've seen tremendous, it is astounding the amount of alcohol consumption I've seen in my patients. And this, of course, has a significant burden when thinking about our patients with chronic liver disease. And we think about populations, generally speaking, that where we see a greater burden of alcoholic liver disease, again, are going to be at greater risk. Particularly if there are populations that we know are also at greater risk for COVID-19. And so as we took a step back after the initial discussion on COVID-19 disparities and established a conceptual framework to think about what's driving that. And here, this is an article that we had in Hepatology a couple months ago that does some of the same thing, but really focuses on sort of this idea of liver disease and disparities, looking at some upstream determinants, midstream determinants, and then downstream outcomes. So we think about the social policies, the societal structure, community, racism, implicit bias, and the role they play as upstream determinants, a number of sort of midstream determinants of health around material conditions, psychosocial, behavioral factors, healthcare access, and then what the impact that they have on liver disease outcomes. If we kind of think about that framework this way, then we can begin to, devise some ways of trying to address the impact that social determinants are having on disparities in liver disease in the setting of a pandemic. And so, first of all, we need to begin to directly confront the idea of social determinants of health. Ask them, screen your patients, try to understand what are their risk factors when it comes to social determinants of health, so that you can have some guidance and provide them guidance about what they may need. You may be able to provide coping strategies, appropriate referral for community COVID programs. We have a couple here in Durham around unemployment and about guidance for getting your stimulus checks. Engaging community partners in connecting your patients with them around food banks or transportation programs, right? And then prioritizing these physicians, patient assistance programs for medications, right? And you think about rifaximin, when you see that patient, you need to write it, ask them directly if there's going to be an issue, and then work with them and utilize resources in your clinic. I've leveraged my pharmacist a number of times in a way that I have not before in the last year to help us get medications to patients who no longer could afford them because they lost their jobs. And then, telehealth can be done. It's important that, again, that we do it with the appropriate infrastructure to ensure equity in that resource when provided. But with our patients with alcoholism, you can certainly encourage AA via telehealth. Try to identify resources within the community. There are some telemedicine, telehealth programs here in Durham that we've been able to leverage as well for many of our patients. And think about how you can really integrate addiction medicine services into your clinic, so that if they do come to your clinic, how can you begin to think about how you can do both of those things at the same time, or try to coordinate with an addiction counselor, so that you're minimizing exposure, but maximizing the time you have to address these issues for your patient. I think we need to really begin to prioritize our patients right now. And I think most of us have done this when it comes to our endoscopy, for instance. But thinking about the same thing when it comes to imaging, we can always consider the use of biomarkers as needed, although not ideal. And then be an advocate for your patients. This is about the fundamental cause of disease that are often beyond the reach of medicine. And it's going to take community and a much more broader effort to address these issues. I do some work with the Durham Department of Public Health. It's some of the most rewarding things that I do. And we're able to really make some headway on a number of health issues here in the Durham area in that capacity. I've also participated in the ASLD Capitol Hill Day, which I recommend you all do. It's a lot of fun. And it's a way to, again, be an advocate for your patients in your area. And finally, I'll say, I think that we, at this moment in our country, have an appreciation for the role of things like structural racism and bias, and appreciate it for it in a way that we've never had before. And I think that many institutions, academic institutions, are taking this time to sort of reflect on where they are in this respect and how can they improve, move things forward, and be better. And I think we need to do the same thing in hepatology. How can we, as a transplant program, be more anti-racist in the way we evaluate our patients? What type of training can we do for our staff and for our faculty to ensure that we're treating our patients in an equitable fashion? I think this is the moment that we can take advantage of where we're at right now to make those kinds of changes. And that will not only be a tremendous benefit right now, given the pandemic and the disproportionate burden of it on communities of color and poor people, but certainly will have an impact moving forward. I'll stop there. I really appreciate the opportunity to come and speak to you all. I'll be happy to answer any questions. And thanks again.
Thank you, Julius. This is outstanding. It just hearing about it, the same issue that we have been seeing, and just looking at the firsthand, all of us, it just important that we all have to change. So there is one question that it's from the audience, that has your program changed its transplant protocol for alcohol-related disease to account for disparity in access, like African American community and others? Have you had any?
No. So no, that's a great question. We have not changed our protocol about that. But I think that's something that we need to do, and we need to look at that closely. We are just, I think, like many programs, particularly in the United States, very reticent to engage in that. But as you all know, there is some large data and research going on right now to help us better understand that in the United States. We have not, but as we reflect on how can we do a better job of serving our communities, particularly with that valuable resource, I think thinking about what we do with alcoholic hepatitis and our patients with alcoholic liver disease, I think thinking about how we define social support. A lot of times, if it's not your wife or your, a child, we don't think it's a real quality, strong, reliable social support, but a lot of times social support can be a very different thing depending upon who you are. And I think, we need to think, and I think to the issue with alcohol, sometimes looking at one patient, you may say, oh yeah, I think he's okay. We'll go ahead and list him. And another patient who looks a little different, you may be less comfortable doing that. And I think that's where bias comes into play. And I believe bias training can help a lot with those kinds of decisions as well.
Excellent. So one other question that, you have point towards about alcohol and, the food insecurities. What about the mental health, which were already we were not doing good job, I think, in our liver patients, and this has already we're seeing like all these things. So what are some of your recommendation or some suggestions to all of us?
Yeah. So, I think that it is important that we begin to think about how we can do a better job in our liver clinics of providing truly interdisciplinary care. As I spoke to in the talk, of this idea of trying to engage, like, counseling around alcohol use, and how can we sort of bring that into our clinic. I think we also need to bring in more psychological mental health services into our clinic on the regular as well. Regular screening on our patients, particularly right now, given the burden of the pandemic and what we know it's doing to our communities. We're really engaged in that and doing a similar thing where we bring that sort of those types of services into our clinic and offer them early on. The dividends immediately probably would pay off immediately, right? In terms of what our patients would experience and what they would benefit from that. But even thinking down the road, when thinking about transplant, what would it mean, in terms of this patient having had the mental health care they needed way before we had them, evaluated by our psychiatrists or or a psychologist prior to their transplant evaluation. And so I think there would be a lot of benefits in our liver patients to incorporating that into our clinic early on.
Mike, you are muted. I think our co-moderator Mike has a question. Please
Perfect.
go ahead.
Hello.
Yeah.
I don't have the power to mute myself here. Thank you, Dr. Wilder, for your discussion. I appreciate your discussion regarding disparities that have only become more apparent in the COVID pandemic, unfortunately. But given your experience, how has clinic flow changed as a result of the pandemic to maintain equity of care as best as you can? And what do you recommend to other hepatology practitioners?
Yeah, flow's been, it's honestly, it was quite frankly a little chaotic. It felt like for a while there in March and April. But I will say that, and I give our leadership a lot of credit, they very quickly were able to get us into telemedicine. And when they brought us into telemedicine, I thought a key thing, to your point, Mike, that I think that clinics need to do is ensure that you have the infrastructure to help ensure that patients are getting what they need. And so, when I would be on a clinic visit with the patient, if there was an issue with the connection, like they weren't connecting, which often was an issue, there was a person who I could immediately text, and he or she would then directly call the patient, and they're on the phone with the patient while they're texting me, telling what's going on, telling me just wait. And so that sort of infrastructure in terms of IT, I think is really important so that we can ensure everyone can take advantage of telemedicine. But I think, in the end, a lot of this is going to be advocacy as well, because there's nothing that we can do about what our patients have at home in terms of resources. And so, in some of that, I was talking about some of the things we do with the Durham Department of Health, and we've talked to them about how can we begin to think about how you can build that infrastructure for better internet access for patients, in different parts of, our region that have limited. If you go like not even like 20 minutes, 5 miles, you can still see a tremendous difference in terms of internet access. And so we really need to partner with the health system and with your local governments and be an advocate about trying to ensure that they have those resources. I think that's really important to do because, again, moving forward, I think telemedicine is going to definitively be a part of the care that we provide. That having been said, until that happens, I think ensuring you have that infrastructure that will help patients navigate issues when they come up. I think it's going to be important to make sure you have phone on backups that you can at least talk to your patients. I've even done FaceTime with patients with their iPhones as well when I had to.
Thank you so much, Julius, Dr. Wilder. I know that it's 8:30, and it is, I think we all have to work on it. It will only gonna get worse. Our hope is that, leaders like you can guide us through this difficult time and we can provide the best care possible to our liver patient. Thank you again. And we will gonna move, and I'll pass on to Mike to introduce our next speaker.
Okay.